I'd like to call the meeting together to order today on September 19th, 2023 for the Health Commission Community and Public Health Committee meeting.
Thank you. I will call them the roll. Commissioner Gerardo
Present.
and Commissioner Chun.
Present.
I will also read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second item on the agenda today is the minutes of the August 15th, 2023 committee meeting. And I will note, I'm sorry, before we move forward, that Commissioner Gerardo has a correction on page 1 under Commissioner comments, paragraph 2. It should say the corrected minutes will say Commissioner Gerardo asked if the DPH would consider partnering with the San Francisco Unified School District for supervision activities.
So I'd like to make a motion to approve the minutes with the change.
I second.
Great, and there's no public comment? So all we need is all in favor?
Aye.
Great, fantastic. So we can move on to the first item, and folks who are watching this at a later date or who are watching it live, we will switch the order today because our first presenter is caught in traffic. We'll start with item 4, the HIV Health Services update. Mr. Blum. Bill Blum. I'm sorry, Blum.
I'm a Bloom, but it's all good.
Okay.
Can you guys hear me okay? Great. Good afternoon, Health Commissioner. It's great to have a chance to speak with you both and share a little bit about HIV Health Services. And you've got the slide set running. Thanks. My name is Bill Bloom. I'm the director of the program. So the first thing I'll share with you is our newly minted mission statement, which is the work of our staff. Oh, sorry, next slide, please. This is the work of our staff as well as a lot of community input from the planning body and colleagues and stuff. And we kind of an oversight role, and our job is really to ensure the quality of services and the quality of life for people living with HIV who touch on our service system within the DPH. And the other big role we have is really we do a lot of collaboration with multiple levels of government and multiple stakeholders in our community and multiple consumers as well. And our goal is really to maintain and to grow the HIV service system. Next slide, please. This is the chart, and I know a few of you, and I believe it was you, Commissioner Gerardo, who asked a little bit some questions. So I think there were 3 areas. I'll try and make sure I cover them at some point in the slide set. And if I don't, if you want to interrupt me, please do, or at the end, we'll have time for questions. So we're the small, the mighty, and the brave. I guess you can see from this slide set. We sit within ambulatory care. And report up to Dr. Colfax. You can kind of see we're a direct staff of about 8. We currently have 2 vacancies, which we are anxious to get filled. And I think there was a question, well, that's not a lot of staff and it's a lot of contracts for people who looked at it. So, and it wasn't enough, I think was the question. So first of all, can I just say thank you for that question? Usually it's, can you do more with less? So there was a lovely question. And to be truthful, the first part of the answer is, these are the folks that sit in the HIV Health Services unit. We both support and are supported, and that means both financially as well as by staffing time, by a lot of other folks in DPH, primarily in the business office. So Ryan White Programs Grants both funds them, and a lot of folks that are funded by general fund or other things support the work we do of HIV, particularly around contracted work. So the first answer, it isn't just us making all that magic happen. So that's kind of the first part of the answer. The second part of the answer, and I'll try to only say it twice, is I have like the best and hardest working, smallest staff in DPH. So they're super hardworking. They just about never say no, and even though we're down 2 people, they step up and we make it happen. I think if I could have another staff person, I would. I wouldn't have 5 more, but it would be great to have 1 more, because we are to a place where one of us is actually on a reduced schedule. We could just see where it's super lean. And I think there's a lot more work we could do around the system, the outside community system. You know, we are able to monitor and make sure it happens, but we now have 1 new position, our first in 10 years, who actually goes out and interacts a lot with the providers and kind of sees where there's areas where they can improve coordination or people that aren't trained in a certain area. I mean, just kind of looks at the quality of services. So in a wonderful world, yes, certainly 1 more would be great. I'll go on to the next slide. So I wanted just to give you a sense, and one of the ways that to give a sense is to know what the budget is. So you have a pie chart kind of showing you the different sources, and below are the different kinds. If you look at kind of the red, you'll notice there's some red script throughout the presentation. That's kind of a key point. Basically, between Ryan White Part A and general fund, that makes up the lion's share of our budget. But you can see we also get other stuff. There's a federal program called the Ending the HIV Epidemic, EHE, which I'll talk a bit more about later. There's also Ryan White's Part B and C. We also get a little Part D, and then there's also Getting to Zero, which is which is kind of HIV specific general fund that goes to support HIV care, both prevention and care side. All right, next slide, please. And if folks want a breakdown of the different parts, let me know, and I'm happy to give that. So you can see here, this is the majority. There are 22 services that the feds define as categories of service that we use Ryan White programs for. You can kind of see they're divided in 2 things: core services, which in Medicaid speak or Medi-Cal speak is core services are the essential benefits package, and the support services are all the wraparound services. So these are all the different services we provide with the funding we have. Of note, on the right-hand side, the Center of Excellence, that is a kind of a one-stop shop model, which we have developed over 20 years, which is about as close as we get to a patient-centered medical home. If you all probably heard that from my colleagues in primary care. So it's the idea all the services are on one site. Sometimes it's a single agency, sometimes it's a collaboration. Next slide. So, you know, another way we measure who we do is who we interact with. So on that top line, and I won't go into all the other lines unless there's a question about it, but we have over 65 contracts or MOUs. I'm on slide 6 there, and 79 programs. So some agencies have more than 1 program, and we interact or have contracts, or they subcontract with 42 different CBOs, as well as UCSF and sister programs within DPH. And you can see a further breakdown. On the right, you can kind of see the logos or the branding of a number of the agencies we interact with. Next slide, please. So this is kind of a map on slide 7 of all the different programs that are funded with HIV Health Services dollars. And I think probably what's of note there is we have a pretty good geographic match to where the majority of the clients living with HIV are. You'll kind of notice the central spine. There's some services in the southeast sector of the city, as well as the TL, which is again the majority of our clients, and then some south of Market. Next slide, please. To give you a little bit of a sense of who we serve. And what you have here in the green is all of San Francisco. So if you look at, I'm sorry, I should say, the greener is part of the 2 charts there. It's all of San Francisco compared to HIV Health Services. So our safety net, DPH safety net. So you can kind of get a sense of how the folks we serve compared to all the people living with HIV in the city. Not striking differences, but some differences worth note. More likely to be people of color, more likely to skew younger and older, probably similar to what you all see with other presentations from my colleagues. Next slide, please. So the next is around EHE. So our former president came up with the goal or announced it in one of his State of the Nation addresses, this idea that we would end the epidemic. It became called EHE or ETHE. It was an initiative. The goal you can see there on the right was a reduction of HIV infections by 90%. And then also getting everyone in to know their diagnosis and get them into care. It was set up in kind of two waves. The first wave was called the Tier 1, of which San Francisco was included. And so if you look at the map on your left, that shows you all the Tier 1s. It was allocated at almost $300 million. And that was kind of allocated to different agencies at the federal government. For HIV care, it's HRSA HAB, which is HIV AIDS Bureau, and $70 million was allocated for care services, getting people into care and keeping them in care. So the next slide, please. So, so again, as I mentioned, the goal on the left of the EHE is 75% reduction in new infections in 5 years, and then up to 90% reduction in 10 years. And then if you look towards the right, you can see by the bar graph, the increasing fund each year. The idea was that funds would continue to grow. We're on the year four now, starting year 4 of a 5-year cycle, and then hopefully it'll be renewed for another 5-year cycle. Next slide, please. So locally, what we wanted to do with the EHE dollars is to really be true to the spirit of the legislation, which was to enhance those services for populations or groups of people and individuals that weren't getting the same health outcomes. So we wanted to get to equity of health outcome, which in this day and age with HIV, we measure by virologic suppression. So get them in care, keep them in care. And we were epi-based, and I think you've probably seen presentations. And the 4 populations here listed 1 through 4 are the populations that we were just seeing over and over again. We've seen for a bunch of years that just aren't getting to the same levels of virologic suppression. And so this is where we're going to focus the money, which is not to say that other groups living with HIV couldn't use more services. I think most people on the planet could use more services. It's just we wanted to be true to the spirit of the legislation. We also do have a focus on Black African Americans as well as Latinx communities. What we notice actually is that we have a disproportionate number of people that are Latinx identified testing positive relative to the population. However, when we look at analysis of getting in care, staying in care, and being suppressed, they're actually higher than the average. And then with the African American communities, we are augmenting and supporting programs that work primarily with African American populations. We are hopeful as new collaborations form that more funding and actually can be an African American specific project. But there are 3 agencies that are focused on serving African American communities that we currently fund. You can kind of see some kind of snapshots to just give a kind of a view of the folks that are funded through EHE dollars: trans women, marginally housed, incarcerated folks, and people who inject drugs. And you can see that some of them are a 9-year span, and then incarcerated people is 1 year. We just looked at, we fund a program in our jail called HIVIS, and so that was the number of people that folks funded by our services touched. The program's called HIVIS. And Mark, could I trouble you to maybe wait, hold on one second. After this next slide, maybe we could switch to the other slide set.
Okay.
Here you can see our partners who we fund. We really made an effort to make sure that the funds were kind of shared as much as possible equally amongst community members, UCSF, as well as DPH units. And we based it on who was serving the population and who could get a program up and running, because you probably all have seen this was all happening during COVID. And so the priority was getting the services out to the clients that we knew needed the services. And then on your right, you can just see a similar breakdown of the pie chart about how much of the EHE funding goes to each of those kinds of services. So Mark, if we could switch over to the other slide set I shared for a minute. So I think you all had some questions of like, what difference is EHE making? What are some of the stats? So I'm going to share that briefly with you. I'll focus on the first slide and then just give you a couple of other slides. And if you want to ask more questions about it, then we can do that.
Okay, give me 1 second.
Should I be masked? I just realized that I'm okay. Okay.
Okay.
Okay. Boy, am I glad I brought the cheat sheet. My eyes can't see that. Yeah, I guess you guys can relate a bit. So, so this is looking at unduplicated clients and units of service in the programs that we fund, as well as a new program. So you can see the San Francisco Community Health Center, which was formerly API Wellness Center, 2 programs we fund there with EHE funding, TransAccess, and then H Home, and you can see the numbers. At Ward 86, we fund Pop-Up, which is a service primarily focused on people experiencing housing instability or homelessness, as well as mental health and substance use. It's a drop-in service on demand, kind of one-stop shop, as well as Splash, which is starting the long-term injectables. So that's an injection clinic. Then in UCS, AHP, Alliance Health Project, we fund both medical case management as well as psychiatric consultation. That's actually a warm line for folks that are trying to figure out with polypharmacy what's the best way to make it work, and with the focus on mood and thought medications. And then finally, within the Department of Public Health, whole person integrated care, we fund street medicine, HIVIS in jail, which I've also mentioned with expanded services, and Tom Waddell Urban Health and Castro Mission, another long-acting injectable initiation. And then finally, Gender Health SF, we're funding half of a position there to do case management. So again, you can see some numbers there. If you want to skip over the next slide, please, Mark, and go one more. So you can see here the demographics, again, comparing folks in EHE, which are in the red, to all the clients we serve overall. You can see much higher percentage of folks that are experience housing instability, a higher percentage of women, both cis and trans, a higher percentage of people who are under 45, so a younger group, and then a higher percentage of people who identify as a person of color. Next slide. This kind of just shows you the overall trend. You can see the numbers increasing, a slight dip. We're thinking not all the data has gotten in, which explains that, but you can see over the years increasing numbers. Next slide, please. And then looking at viral suppression rates. So this is looking by gender, and we are comparing the average, which is in red, versus the different viral suppression by gender. So looking at cis men, cis women, and trans women. Have called out trans women distinctly because of differing health outcomes as opposed to biopharmacokinetic stuff. So that's why we have those 3 groups. We don't call out trans men just because the N is so small that it would not be statistically meaningful data, and we also don't want to out anyone. Okay, next slide. And then we're looking at viral suppression. You can see the increase over time that's been impacting the program. That's looking at the either at the red numbers, you can see a percentage, or the gray, you can you can also see a percentage by month. And it's comparing the overall rather EHE clients with all HHS clients.
And commissioners, I'll forward these slides to you so you have them.
So I'll go, did that answer the questions you had about impacts? Yes.
Oh, well, actually, I have one question about the definitions for viral suppression. Is that based on, under 200 as in undetectable?
Correct.
Because, WHO is trying to come up with a slightly different definition. And that is like viral suppressions means under 500 and undetectable is under 50 copies, I think.
Yes, it is currently, we're looking at 200, but most of the labs, they go down to 50. So we actually, when we load the data, we are using the 200 mark. And so it's actually some data cleaning. But yes, there is definitely different thresholds, and it continues to emerge, as well as different beliefs on the number of medical visits for someone who's been durably biologically suppressed. So yes, a bit of an art and a bit of a science, but 200 is our gold standard. I'm going to shift this. Thank you. It's that kind of bewitching hour of the afternoon. So we're getting near the end. So next slide, please, Mark, from the other
On
side.
this one or the original?
I'm sorry, go back to the original.
Okay.
And then slide 13.
Great. Give me 1 second. I have to close that out.
So maybe while he pulls it up, I think there was we had expressed a challenge and then there was a question about training. So maybe while he pulls it up, because I don't have a slide specifically on that. So we do have a training program which we're reinvigorating. We had a staff that promoted from within. And so she's done a good landscape analysis, so we're not repeating the same trainings. The other good news is that we shifted the funding. So when it was federal funding, it was super restricted and they had very narrow, they were kind of looking at biomedical markers and we were kind of saying, you need a trained workforce or we're not going to get there. So she's looking at that. There are a number of initiatives and we're going to develop trainings that are responsive to those. What we're mostly finding is there's two kinds of trainings. One is, HIV people used to come and sign up for a lifetime because they were mission driven. And as HIV wonderfully becomes more chronic and, people are, they're seeing it the same way one might see diabetes or other things, which is to say, this is great. I want to do 3 years here and 4 years and, dealing with coronary health or whatever other things they're interested in. So we're discovering we need to do more around training. And so we have developed a lot of cheat sheets. I have a new staff person, Andy, who's kind of a veteran social worker. So we're sending that out. And we also fund a group called FOG, which is Frontline Organizing Group, which has about 70 case managers, as well as social workers, as well as benefits counselors. And they have boot camp where they do a lot of that training. And so the work that our HIV trainer is going to do is going to wrap around that. What we're discovering is we need to keep people invigorated, passionate, finding meaning in the work, and support around kind of staying with the clients that are more challenging and, stuff like de-escalation, maintaining professional boundaries, as we also get a lot of folks. We're trying to get more folks from the community to provide the service. So there's kind of stuff that's cooking and stuff that's already there. And we have the slide up now. So, we're legislatively required, and this is a national thing, that the community both plans the nature of the services and then allocates the money by service category. If you remember that series of squares I shared with you, which is kind of unusual. There isn't many other programs that I'm aware of that it actually gets to the level of both the pen as well as the pulpit. So we spend a lot of time and work with the community board, which now actually does HIV prevention and care. So we're a combined board. And they meet yearly, and you can kind of see here a little bit about their mission. We try and have at least 0.5% are consumers, people living with HIV. Sometimes we hit it, sometimes we do even better, and once in a while we struggle to get there. We have a lot of long-term survivors. Kind of the newest, it's not really a challenge, is that the feds are wanting us to do term limits. So we're trying to figure out ways that we can respectfully have people stay engaged, but maybe give up a voting seat and kind of participate with us in other ways. But we're looking for every way possible to keep everyone as long as possible and get them back in, because you all are probably aware if you even respectfully say goodbye, you can't always get them back, even if you want them. So, but we're working on that now. The feds have just kind of put that out and shared that with us. Next slide, please. So there are two CQI projects that we are working on. The first is, and it's all around viral load equity. And so the first is working with our Black African American clients. We started in 2020. Our goal is to get to 87% viral load suppression, which is kind of one of the federal kind of benchmarks. And we've gotten to 84%. And if you look over a period of 10 years, it's gone up 12 or 13%. At times, actually, we managed to completely close the gap. There wasn't a difference. And then it would pop open. Statistically, it's fairly small. The group decided to continue to make that actually a main metric as opposed to a watch metric. We have a CQI meeting primarily of medical providers, but also medical case managers. And we had 30 people in the last meeting representing probably about 9 different clinics and programs, and they wanted to keep that. I should give the caveat, this is once we get people into care. So this is, you at least got referred to and made it to one appointment. I think for the folks that are not yet in care, I think it's probably still is disproportionately African-American. And so I'm not sure that we're completely there yet, but a lot of progress, which I guess hopefully that speaks to our system caring about this. And also just when you give people data, it kind of helps people stay focused. In 2022, we added another, which is people experiencing unstable housing. Our goal, we were currently at 74%, and we want to get it to the same national metric of 87%, and we're currently at 74%. So we're just starting this process. Again, this is people that have touched our system and got to a clinic. It's not the people that are not making it in. We have a whole other set of activities for them. But this is a slightly prettier picture than the whole system, but it is the work that we're doing because we got to get them in before we can start to do that process. Next slide, please, Mark. So I'm going to spend a lot of time on this because I don't think it's necessarily very different from a lot of the other folks. So I'll just kind of call it out, kind of the ISM structural challenges. Housing instability and homelessness in a terrible housing market, kind of a higher proportion of folks living with mental health issues and at high risk or uses of substances that are leading to challenges in their lives, particularly methamphetamine. And then, we never had this problem. So that fourth bullet is just hiring, retaining, and training workers. Again, I think that's a reflection of of just HIV becoming a treatable disease and people, coming in and wanting to have other experiences. And I'm sorry, that last bullet's a repeat. It didn't, the wrong slide came. So we'll skip that and go on to the next, which is successes. I think we are particularly proud of EHE, just what we've been able to do and the populations we've been able to focus on. And you all saw some of the data. Also the success around the viral load suppression. Again, sharing the data and people caring does make a difference. We've been able to both kind of support and expand trans-affirming care services. Telehealth was kind of a mixed thing, but I think it did provide another option, and it is an option that not all, but some of our clients prefer. So it's great to be able to offer that. I think it helps people stay connected in some ways. And for people that don't want to be out and about, particularly if we have another outbreak of COVID, it's nice to have this. We also have tried, and we're still in the baby processes, but we used to have, if you were positive, you got services here, and if you were negative or hadn't tested positive, you got services here. So and that had to do with the federal funding as opposed to necessarily our vision. But now we have this opportunity actually to jointly fund one person with both kinds of funding to work with everyone. So status neutral is kind of the term, and braided funding is what the feds use for it. So we're kind of starting that, not without its challenges, but we're excited to be able to offer that. So you just come in the door and it doesn't matter your HIV status. And then we're kind of very excited about the long-acting injectables. I hope to come to you in 2 years, or if I'm no longer here, someone else, and say it's gone to Q 6 months or Q a year, and it's just, we're able to really get everyone in, because a shot once or twice a year, I think, will be a game changer. It's currently every 2 months, which is certainly a huge help, but I think it needs to be more client-centered than that. So hopefully we'll come back to you and tell you that the scientists have made that possible. Next slide, please. So I have the world's best staff. I got to end with that. I'll compare them to anyone in the page. So just a little bit of a shout out to them. Beth, who is the assistant director, also has the other job of Healthcare for the Homeless grant. So that's how we are able to derive our FQHC status in San Francisco. So she manages all the grant reporting. I don't know how she does it all. John Ainsley, who does budget data and reviews all our contracts, and also is the person that provided you with all the graphics on this slide set. Nina, who provides administrative support, who is about the world's sweetest person, very personable, and she can make anyone feel comfortable anywhere. Maria Lacayo, who has been recently promoted. She's over the AIDS Drug Assistance Program. She's also working with me in the Planning Council. She also does data, CQI, and training, which is the program I mentioned to you. We're spending a lot of time on that now. Flor Rahman, also recently promoted, will be over Aries as well as HIV Care Connect. And she actually has kind of been the subject matter expert for the State Office of AIDS. They've relied on both her and Maria a lot to figure out how to make the successor system work. And she also has started to take on more racial equity work. And finally, Andy Shear, who is our newest staff person, is the coordinator of all EHE services. And the great thing about having someone dedicated is he actually can get out in the field, which we're not able to do. So that wish I had was kind of based on watching what he's been able to do. So thank you guys for the time. The post-lunch is always a tricky time. Hopefully you guys got the right amount of carbohydrates and I didn't put you to sleep. So I will stop and see if you have any questions.
And commissioners, there's one person on the line, so I'd like to, if you'd like to make comment, we're on item 4. We started with this item because the presenter for item 3 was caught in traffic. Please press *3 if you'd like to make comment. All right, I don't see any hands, commissioners, so please feel free.
Not so much a questions. Well, I was mesmerized by all these like animated graphics, by the way. Like
Please do
it's
let them
different
know.
when it's on paper and versus, you know, on the screen. I was like, okay, so back in my days, you know, like the category of RCFCI seems to be disappearing from, you know, the services, but I also see MyTree pop up. So, so how are we actually funding those services right now?
Residential facility for the chronically ill, RCFCI, that was a state level designation for skilled nursing facilities. That was designed about, I think, probably 14, 15 years ago, and it actually came through Ryan White's Part B. So it was state, and the states did a pass down. It was really designed as a medical model. And then as folks got more stable, who was needing the services was often that group, but added in more kind of a social model, people who just the challenges of whether it was either kind of controlling substance use so it didn't leave them in a chaotic spot, or mental health stuff, and or like lighter systems that maybe weren't fully meriting a nurse, but needing someone to do medication management or just help, you know, because chronic diseases, people not walking well. So for a long time, the state actually wanted to get out of the business because it didn't look like the other kinds of like, RCFCEs, like for the chronically elderly, it was kind of something a bit different. We did continue it for a long time. And I think in San Francisco, we had the added challenge that we didn't really have the housing to transition somewhere to somewhere new. So you're probably aware our colleagues over at MoCD, Mayor's Office of Community Housing Development, they manage the HOPWA funds. And so they were kind of looking at how do we grow, transition this, and they used a model based out of LA, which was more of a social model, TCRF, transitional residential care facilities. And so then we were working now to transition folks, some of for whom it's worked wonderfully, some it hasn't. We do still have our CFCIs, and MyTree is one of them. They actually are both a hospice as well as a licensed RCFCI. We transitioned 2 of the RCFCIs, so I think the short answer is it's a smaller number. It's still there. We are trying to develop the housing pipeline, and in some ways it's been successful, in some ways it's not. It's been hard on some of the clients. We've done a lot to support them, and we need more housing. That's going to come down to it.
So that's a second question. So like, I'm glad you mentioned FCE, because like when you look at the data, it seems like, you know, like the general HHS data, you know, like people living with HIV are aging. And so, you know, like there are a number of like over 50 and living with HIV are increasing. So what are some of the discussions happening right now in terms of like augmenting services so that, you know, there will be more integrated care for them?
Yeah, it's a great question. And now we are starting. perhaps we should be further along. So, we have one program that is specifically for folks that are elders or people living with HIV. And you'll remember this, I think, Commissioner Chung. I remember when we were designing these centers of excellence, we said, well, should there be one for people that are older? And no one wanted to do it. People were open about living with HIV, they were open about anal cancer, but somehow the idea of going to a place for old folks, we tried to get traction, and the planning council was like, no, we don't want to separate old people. So it's funny, 10 years from now, we're having a very different conversation. And so, our what used to be called CCHAMP is medically complex folks. And so it's kind of a surrogate marker, because what we mean is the medications are no longer working for folks more in that, and it's on the whole an older group. And then there's a carve out within that called Golden Compass, you may have heard of. So that's absolutely happening. We're also looking at augmenting kind of the mental health services for people living with HIV that are long-term survivors. Now, it seems to be we're coming to a definition of long-term survivors as 50 plus, which as I get older and older, it doesn't seem so old, but it is kind of a reflection, at least you're not on that side of the timeline, right, on this side. And we're probably in the next 4 or 5 months going to have a written report to figure out how we grow those services some more. And actually, the patient need is driving it. Like, I think geriatrics became a specialty in the 80s, but it's forcing many of our infectious disease and even our family docs to start to get expertise for aging, because there are certain kinds of things you have to do more testing on, like risk of falls, independence in ADL, some light stuff around cognition, because we know that even controlled HIV, there may be slight shifts in terms of just cognitive focus and acuity. But the big thing is polypharmacy, all the medications, and we know that as people get older, we need to be strategic so they're not popping 20 pills. So that's kind of the direction that we're looking at. The system has started to add farm techs, but those are usually folks that clear and get the medications approved. But I think in the future, probably we'll be looking at adding more pharmacy. And I think that we'll need to have more pharmacists helping.
Thank you.
Have I answered your question?
Yeah, it also brought back a lot of memories.
Yeah. Yes.
I have a couple more questions,
Sure.
but thank you. This was a great presentation
Thank you. Thank you. It's an honor to be here. It really is.
and really informative from a year ago to what's going on now. It's great. But I still am wondering how you're able to monitor those 65 contracts and 149 programs, as well as the 11 different units of DPH.
What the hell happens? Yeah, that's a great question.
I mean, I'm reading this, I'm like,
So
okay, what's the duplication, or how can you do it with, when I look at
yeah,
all
no,
of
it's a fair
all of the centers, I'm like,
It's a fair question, and actually our federal providers are asking the same question. They want us to do more, so we're going to do more. There used to be an AIDS office back in the day, and the HIV health services, which is the care part of it, we used to be a staff of over 20. And through various different restructures, there was kind of centralizing, and a lot of the contract and monitoring moved over to what's called the business office. And
right.
the good side of it actually was when they looked for this job class HPC3s, there were a lot of them in the HIV shop, and HIV health services. So they all moved over with the expertise. So in a certain way, we kind of were like, cool, because it meant that, the standards and the stuff we had designed kind of got implemented there. But the downside of that was just to be able to be in the community, be interacting with the programs, do program improvement, the stuff that I've mentioned, like every one of those folks had like 6 to 8 different agencies, and they managed the contracts. So we lost that. And so what came in place is a system of care. And, I get around as much as I can, as well as Beth, but it's, it could be better. But in answer to your question, the contract compliance folks, they have a yearly thing. We have a very complex spreadsheet. We have 240 objectives, which we tie to all the contracts. So it's like a spreadsheet that's about this long with about 8 print. And so we provide them with all of that. We also provide them either through invoice or through a client database they'll have to use, the units of service in the UDC. And then there's, of course, a number of standardized things any agency has to have, you know, like the audits as well as the signage and all the stuff. And we send all of that over there. And then they do all of the monitoring and they invite us. So what we used to do is we used to kind of pick either folks that were doing interesting and new things or folks that we knew were struggling or folks that we wanted to perhaps make some changes. So we were hitting maybe a quarter or a third of them. And now we will be hitting everyone that's funded with any wider EHE. And then hopefully when we're full staff, we will also join them for everyone at the site visit. So hopefully next year we'll be a member in. But yeah, it's a pretty robust monitoring system, but it's not the same as us as SOC folks doing it.
Well, that's what I'm also wondering. I mean, because I'm familiar with what the business office does
Mhm.
and their monitoring, but who makes sure that the services are not duplicated in?
I see. So the deduplication piece is what you're asking.
Yeah, I'm concerned. That's one of my
Okay, no, that's a
questions
good
is
question.
duplication.
So that, you know, every unit of service that they charge either to a general fund that's HIV specific, that comes from and originates in our office, or all of the federal funding, they have to enter the data, the patient name, as well as the units of service provided. So there's no way to double count a client, and they have to do it by contract. So
Okay,
it's not easy, wouldn't be easy to double count on.
okay. I mean,
And that's the monitoring system, the ARIES.
Aries, yes, and it's going to be replaced next year by HIV Care Connect, but the same program, it's a state-funded thing.
okay. Then my other question is with the population focus, I don't know which number slide, on ending the HIV epidemic, the
Uh-huh.
EHE, with the 4 target populations where you've got the numbers listed on the bottom of the
Mhm.
slide,
Yes.
and that they have not engaged in care in the past. With these folks,
Mhm.
have you made any headway, let's say,
In terms of virologic suppression, and yeah, so if you look, so the answer is yes. And the additional slides that I
Yeah,
shared with you,
okay.
which you'll have a chance to look at, you can see one, that the trends of over time and also the increase of viral suppression rates. And we looked at gender as well as race, ethnicity.
right?
And you do have the slides, and the short answer is yes, it absolutely makes a difference. Those services are more intensified, they're smaller caseloads. And on the other side, there are folks that just have more structural challenges. So, you know, and as we have new people come in, we want to see the level go down because we don't want virally suppressed people in there, but we want them to get better. So it's been an interesting thing to track because our tracking systems aren't that sophisticated to say, like, if you've been in a year, are you virally suppressed versus. So it's a funny metric which should wobble up and down depending on how many new people are coming into the system. But yeah, we do see improvement over time for people in the program.
So let's say, and because you've got very specific numbers here.
So if you look, those are, and it's a little bit of a mishmash. I should have explained it a little bit
Okay,
better.
help
So
me.
you're looking at a 10-year window. So if you look on the left, 106 trans people identified as trans women were diagnosed in a 10-year time frame. And then if you look at people that stated at the time of diagnosis as well as their housing status, that's 409. And then it's a different kind of statistic. The third one, I need to rather switch the order. So there's about 221 HIV positive people that received services in our county jail.
Okay,
And then the last one goes back again to the 10-year window. This could be a clearer slide. I'm going to rework
okay.
it.
And then you are collecting data, let's say, on this group post 2019?
Yeah, we just wanted to give you a 10-year window because
Okay.
we don't quite have another 10-year window yet. Like,
I didn't know if it was, you're waiting for 10 years or
No,
5
no, no, we
years
just-
or-
what we just wanted to do, sometimes like what are some salient, because you can get lost in a sea of numbers. We just wanted to give you a sense of numbers on that. So a little bit that like that's who's testing positive, and this is the numbers in these groups, and that's the reason why we were wanting to focus on these groups. The other companion piece is that when we compare the viral suppression in these groups, it's lower than the group as a whole. So that's why we wanted to focus the money on these.
This also gives you a better way to compare this with federal data. That's how some of that was reported anyways, right?
Yes. And we use a harder metric than the feds do. So the feds use a metric because they want to make it an airtight so the funding continues. So they use the cascade, the care cascade. It's like everyone who's in this groups moves over to this group. So you have a shrinking denominator. And so the numbers look very good, but we said, oh, no. Once you make it into a clinic once, we got to figure it out. So some of the slides that you'll see, I think there's one in that slide set. And then if I come back and give other presentations, we use a harder metric. So, because we were concerned that if you make it into a clinic and you've been seen in the last 2 years, it's our job to get you suppressed.
So let's just say, if I'm putting two and two together, of the 409 marginally housed within that 10-year period, then what you reported that in 2022, you have 74% suppression.
Correct.
So
Yes.
so I'm-
So,
I'm-
yes,
I'm
that would
trying
be a
to
good
connect
way.
the dots here.
Yes. But so it may, so yes, and. So this means this is just who tested positive.
Right.
So maybe people have been here a couple of years and have been HIV positive and diagnosed 15 years ago. So they might be in that other thing. So it's not exactly the same denominator, but yes, we want to get these folks into care.
It's ballpark.
Yes, yes,
I mean, bottom line is care.
yes. I have a boss that's very good at looking at data very specifically. Yes, but yes, it's absolutely in the ballpark.
That's where I'm always looking at,
The overall trend, yeah.
that, the finite. But yeah, that's very,
We are a small little unit, but a lot of the work happens in the clinics. So I should also just say a ton of dedicated folks out there making a difference in DPH. Yeah.
no, I mean, it's a great report. I just wanted to fully
No, I loved your questions. That's great.
understand and make sure that in order to do the work and monitor all of this, that there was,
So grandma said I wouldn't say no
Yeah.
if there was another position in the office.
Yeah, but you're too modest though, because I just want to add that, a lot of folks, in the country, across the country, sees the San Francisco model as the model to really follow. And I've heard so many people talk about it everywhere I go.
I
Yeah,
know the feds a lot, our federal partners often look to us and they often ask us questions, the kind of particularly what provider level folks are doing, because a lot of innovation and next steps happen there. So yeah, thank you.
and there's the HIV, the fellowship program or the training program too, that we had a presentation on, the research group. And they integrate with you as well, I assume.
Susan Buckbinder.
Yeah, so
How does,
how does all of that work?
Yes.
Yeah, so we call it, we have a monthly meeting, which is all the different branches, our arches, as well as the research unit, as well as CHEP, it's just prevention, and also the STD folks. We all kind of come together and we have an agenda which drives it. And then we also, a lot of us also participating in ending the HIV epidemic work. So we do a lot of collaboration and oftentimes we support each other's work so some of the EHE funding actually went into to research, and actually those dollars ran through our HIV section because we had existing contracts. So we do a lot of stuff, and frankly, I learn a lot from my go to the meetings and take notes, and we share out our data stuff, and we hear what they're doing, and sometimes like some of the lessons around because they're all about the grants, innovative grants. So
Right.
we're kind of always have an ear going to see what we might pick up from them after kind of a, you know, because of course the new kind of treatments or medications or systems, they have a finite period of funding, and if something's working well, we want to pick it up. So that's kind of how we work. They are all structurally different. You know, we, HIV Health Services, we sit on the San Francisco Health Network side, and they are all located in the PhD side. It happened many years ago. I don't feel like it stops us from working well together, but we are structurally a little bit different parts of the department.
I'm always concerned with the structure and the silos, that there is communication and some integration. So that's,
I think we do a pretty good job.
okay.
And I certainly, they're super helpful. In fact, someone from Arches happened to have a background in HIV, and he was an epidemiologist, and he's like, can I come to your meeting? And like, sure. And so he was very interested in what we were doing with ARES and HIV Care Connect. And then Dr. Cohen actually assigned him to participate in ending the HIV epidemic, our blueprint, the plan we need to submit. So it does, I think if you were to be with us, you would feel pretty reassured that we work a lot together.
Well, it seems like, you know, like the original Office of AIDS, some of the staff have transitioned to these departments anyway. So, you know, I think that that's why it is so cohesive, and everybody can talk to each other, because
Yeah.
we've been talking to each other for a long time, including our director and
We're
and
lucky
our
to have
esteemed-
Grant because he used to be in, of course,
Yeah.
in CHEP, well, previous to CHEP HIV prevention. Yeah.
and also our esteemed president who participated in the
yes.
ending the epidemic.
Yes. Yeah. Big champion.
And your secretary used to work at the AIDS office.
Oh,
That's right. Even before my time.
Yeah.
Yeah. Thank you.
Well, thank
guys.
you.
If you want further information, please let me know. Thank you for your time and your work.
thank you so much.
Thank you for your work.
All right. We can move on to item 3. Current research and epidemiology of substance use at the Center on Substance Use and Health. Dr. Kaufman.
Good afternoon. Apologies for my delayed arrival. So I'm Philip Coffin, and I run the Center on Substance Use and Health. You can move to the next slide. We are in the Population Health Division in the Center on Public Health Research. Next slide. We are fully grant funded, almost exclusively NIH and CDC, with around 30 staff when including the interns and fellows that rotate in based at 25 NS. And our goal is really to study and support pharmacologic, behavioral, and system interventions addressing substance use and related outcomes. Next slide. We have a large number of projects. I'm not going to discuss them all today. I'll try to focus on a few to give you some updates. Next slide. So in terms of stimulants, we do a lot of pharmacologic research on stimulants. We've tested a number of different drugs, and we still have no FDA-approved medication, but we do have several that have borne some fruit, including mirtazapine, which our director did some of the initial studies on, and we've continued those and had some good success, including the FDA sent us back to phase 1 to do a drug-drug interaction study with mirtazapine based at Parnassus. That's what we call M3. It's our third mirtazapine study, and that's been pretty successful. We're analyzing the first set of patients from that study at this moment. And we also did a study called HINT, or we have an ongoing study called HINT that tests oral naltrexone for methamphetamine, for sort of mild to moderate methamphetamine use disorder. And then the third study is the CURB study. And that one is kind of the big one right now, I believe, on the next slide. Yeah, so that's a NIDA Clinical Trials Network study, multi-site. It's around, you had a couple questions on that. It's around 12 sites, I believe. And it's comparing 2 injectable medications to placebo. They anticipate that to be fully enrolled over the next year. So we'll have results from that in about 1.5 years. The really exciting part of that study is that we haven't done cocaine use studies before. We did one, but it was restricted to sexual gender minorities. This is our first general population effort to address this major cause of morbidity and mortality in the city. Next slide. You can move on to the next one from here. Okay, this is a slightly better version. This study I want to spend a minute talking about. This is our psychological autopsy study called LASSO. So in this study, we gathered data from, it's a collaboration with the medical examiner's office, and we gathered data from the medical examiner, data from medical records, and we interview close informants of the decedents, oftentimes family members, friends, spouses, neighbors, et cetera. And the purpose of this study was really to try to explore what's going on with stimulant overdose deaths, because we know what causes opioid overdose deaths. It's respiratory depression, arrest, and eventual demise. With stimulants, it's really not so clear. And we also don't have any interventions because we don't really understand the mechanism well. So the purpose of this was to really try to explore, do a deep exploration on a limited number of deaths. We're looking at 100 deaths in total. So it's the largest psychological autopsy study, I believe, that's ever been conducted. And it's already borne some substantial fruit. So the people who die from acute stimulant toxicity, AKA stimulant overdose death, tend to be much older. So they tend to be in their 50s and 60s. It's quite rare that somebody in their 20s or even 30s falls into this category. And they tend to have a lot of comorbidities, a lot of cardiovascular disease. So suggesting that, along with a lot of other data, that these are less acute events than the result of chronic disease. And sort of a result of, in some senses, premature aging related to a hard life, oftentimes a life on the streets, and stimulant use, which we know is a major cardiac toxin. And in fact, when we reach out to families, when we did this for opioid deaths, we reached out to families and we said we were studying accidental death, and it was fine. When we reach out to families for the stimulant deaths, we said we were studying accidental deaths, and families got very angry because they didn't see the death as accidental. They saw it as a cardiac event. For them, they died of, the lay terminology of just a heart attack. And we had to change our language to premature deaths, suggesting that really it's just the bean counters that are calling these overdose deaths. These are actually deaths of chronic disease in most cases. There are some cases of acute stimulant toxicity deaths that are truly acute. And the interviews with individuals really pointed towards a lot of social isolation in these persons before they died. In fact, just to give you an example of a story of a person who was a sexual gender minority, estranged from their family, came to San Francisco, found a community among people who used methamphetamine, really felt at home in that community and built a life and a family for them. The community some people aged out, some people passed away. Younger people came in, they didn't connect as much with the younger people. They started to develop congestive heart failure and COPD and couldn't make it down the hall in their SRO to a friend's room anymore. And then they were found alone in their room, deceased, with methamphetamine in their bloodstream at age 56 and with all those comorbidities. So it's not like an overdose that we think about where you're trying to prevent an opioid overdose by getting naloxone on the scene as soon as possible. Instead, it's way more complicated. And it also, to me, sounds a lot like the isolation we sometimes see in our elderly. So I've started to think, and I think one of the places this study will lead us towards is looking into some of the interventions that we use for our aging population to try to support community and support socialization, and trying to deploy some of those in the context of people who use drugs and are older, recognizing that many people with that hard living, sometimes older just means 50 and above, rather than 60 or 70 and above. And so that's where I'm kind of going with this study. It's been very exciting. It's really bearing the exact kind of fruit that I had hoped it would. Next slide. So with alcohol, one of our research scientists, Milo Santos, runs our alcohol studies, and he's done some great work. The latest study we published was from Say When. This was a study of targeted naltrexone, meaning you take it when you think you might need it. Naltrexone is an opioid blocker that is known to help people reduce alcohol use. It's approved for alcohol use disorder, and it has a little bit of data in this domain, but this is really one of the exciting studies in that it suggests that you can use naltrexone kind of like, as needed PrEP has been used in the HIV world. So as needed naltrexone, if you think you're going to be out, if you tend to get too drunk at a wedding, you can take a naltrexone before the wedding and you'll end up with just one glass of wine while you're at the wedding. It can be a really impressive medication, and the results of that study were really exciting for people who tend to binge drink. Next slide. We do a lot of work with opioid prescribing changes. We've had several studies of patients in the San Francisco Health Network, and we've identified a lot of issues with the deprescribing of opioids and with people being cut off. We've collaborated with the CDC and HHS in their efforts nationally to respond to patient abandonment throughout the country. And in fact, our work is now built into the California Medical Board guidelines for controlled substances for pain. And they actually reference our website of CHOW, which is the Center on Innovation for Academic Detailing on Opioids. And we've been really in close collaboration with the medical board, with the state, and with the federal government in trying to make the transition away from opioids less hazardous and less dangerous for patients, and try to reduce the sense of abandonment and the crises that patients are facing around the country from providers that are frankly afraid to prescribe opioids. Next slide. Reboot is a study which I presented on before. We did a pilot and demonstrated that this intervention of developing an overdose prevention plan really helps prevent opioid overdose events. We are just about to wrap up the full trial, hopefully in the next month, and we will have data by the new year for that study as to whether or not it worked in a full trial in San Francisco and in Boston, and in the context of fentanyl, because the first study was done in the context of heroin. Some of the preliminary data from the baseline analyses showed that being unhoused and being African American or Black were associated with double the odds of a recent overdose. And of course, we confirmed findings other people have mentioned, that fentanyl use in San Francisco has really transitioned almost exclusively to smoking. We did not find a lower risk of overdose from smoking fentanyl compared to injecting. That's in the baseline data. We'll see how it looks in the prospective data going forward. But my suspicion from this is that smoking fentanyl, while it provides a lot of benefits over injecting in terms of skin and soft tissue infections, bloodborne viral transmission, it doesn't give that much of a benefit from overdose prevention, probably because whereas when you smoke heroin, it takes 5 or 6 drags to get an effect, to get your effect. With fentanyl, it's 1 or 2. So you're not getting much of a titration benefit from smoking fentanyl compared to injecting it like you do with heroin. So we're not getting as much of an overdose prevention benefit, although there might be some ways to provide education around, for example, using just enough to get well as opposed to get high. That might help people avoid overdose events, things like that, sort of helping people to learn how to titrate the smoking of fentanyl more safely. Next slide. We do the epidemiology for San Francisco's substance use, and these are new data in terms of the number of substance-related deaths. Now, historically, we've only looked at acute toxicity from opioids, methamphetamine, and cocaine. This is a different look. And part of the reason I'm looking at this differently is really for two reasons. One, when we're looking at acute deaths, we're not really looking very much at alcohol, because alcohol causes deaths mostly. The number of acute deaths is low. Most of the deaths are due to chronic disease or due to, for example, advanced liver disease. In addition, I've come to believe that a lot of the acute deaths from stimulants are probably actually more consistent with chronic disease than an actual acute toxic event. So looking at it in terms of related deaths, you can see that fentanyl is still the main driver because of the extreme toxicity of the substance. And alcohol actually comes up quite high, and alcohol increased quite a bit with COVID in the years since. And if you move to the next slide, dividing them, I think, is really quite interesting in terms of the non-acute substance-related mortality. And you had a question as to what that means. Basically, if something is listed as an acute drug toxicity, we call that acute. And so that would be, in lay parlance, an overdose. Although that might not entirely be accurate, as I've said, with certain cases. If it's listed just as chronic drug abuse or chronic methamphetamine use, then I would call that a related death. So the medical examiner determined that the drugs were related to the death, but it wasn't an acute toxicity causing the death. So the vast majority of alcohol deaths, for example, and of course tobacco-related deaths would be related deaths as opposed to acute. Any other questions about that?
So it was my question. So it was non-acute. So what you're saying is those would be in the non-acute category.
Right.
Okay. And then the toxicity
Right.
is in the acute.
Right. So acute toxicity, AKA overdose, versus other related deaths, or not non-acute, which would be other related deaths. So it might include things like, let's say, endocarditis from injecting drugs. Might be a drug-related death that is not an acute toxicity death. Next slide. Of course, this represents the transition to fentanyl, the gray bar being deaths that involve fentanyl. And as you can see, among opioid deaths, we are over 90% of our opioid deaths are due to fentanyl at this point, which suggests that around 85% of our at-risk opioid use is in fact fentanyl use. Next slide. So back to stimulants for a moment. If you look at the red line, that's stimulant deaths in combination with fentanyl, and you can see that the real increase that we saw starting in 2018 was due to fentanyl. There is an open question of, why all these stimulant fentanyl deaths, and I think it's a challenge for medical examiners to say, what caused the death, unless it's really obvious. So if there's a high level of the substances in the bloodstream, they'll include both substances. The stories of these deaths tend to look a lot more like opioid deaths. So in my thinking about it, I tend to take stimulant opioid deaths and I'm more prone to lump them with opioid deaths than with stimulant deaths. They tend to have a lot fewer comorbidities, much less of a sort of a cardiac course, and much more of snoring, respiratory depression related to their deaths. And then a number of them, we don't know how many are due to unintentional exposure to fentanyl. We do know there are some every year deaths due to somebody that intends to use a non-opioid and unintentionally accesses fentanyl. We don't know how many that is. I suspect it's somewhere between 2% and 25%, which is a really big range. And we are trying to come to get a better idea of what's going on with that in terms of what the prevalence of that issue is. Because if it is 25%, then obviously that needs to be a even larger priority of our intervention efforts. The stimulant without an opioid deaths, as you can see, they haven't increased that much. They've risen a little bit, but they've actually been fairly stable in the vicinity of 100 a year for the last decade. Next slide. So this is just taking a model that we developed and applying it to San Francisco. So, you know, as we transition to fentanyl, we know that overdose mortality will increase, and there's not a lot we can do to control that increase. Most of that increase is going to happen whether or not we have all our interventions out there. And that's why we in San Francisco have really been burdened and overwhelmed by this massive increase over the last 5 years in overdose mortality. If you look at it and if you compare this to any other city by the proportion of their deaths that are due to fentanyl, you can see a similar arc of increase in mortality. The green bar there is the deaths we would expect without a good naloxone program. The blue line is the deaths you would expect with a good naloxone program in the context of increasing prevalence of fentanyl. And then the orange dots are what we saw in San Francisco through the years. With in 2020, we were higher due to the isolation that people experienced. And then we were back to where we expected to be in 2021. And next slide. That's all I have, but I'm happy to take questions, and I will take a look and make sure I didn't miss any of your questions.
And commissioners, I believe there's no one, yes, there's no one on the public comment line, so please feel free to ask questions.
One of, of interest is, I mean, I understand when you're talking about the age group, you know, and looking at aging, et cetera. Is any of your research, or not necessarily you, but or other colleagues looking at the increased use of opioids, but also fentanyl-laced other substances in a younger population?
Sure. So we have looked at, for example, the SORT program, which is the Paramedic Overdose Response Program. So we've collaborated with them and looked at some of their data, done some preliminary looks, and we hope to get funded to do a larger study in collaboration with them to really study individuals who report unintentional fentanyl exposure and try to understand exactly what happened, why it happened, how often is it happening, and when it happens once, does it happen again? Which would open the door to certain interventions. For example, there is a medication, extended release naltrexone. It's a long-term opioid blocker. It might help somewhat for stimulant, to help people cut back on stimulant use. It certainly doesn't stop people from using stimulants, but there's some hints that it might actually help them reduce their use, and it blocks opioids. So if there is a lot of unintentional opioid exposure in that context, then that medication might actually help to save quite a few lives. But we don't know how prevalent the issue is, so it's hard to say how many lives we would save with this intervention, and it hasn't been studied yet in that context. In terms of other substances, there tends to be a lot of media about, saying that it's in everything. I wouldn't say it's in fentanyl's in everything, but you definitely do see it in stamped pills, for example, and mistaken for methamphetamine or cocaine. We don't really think people are intentionally putting fentanyl into methamphetamine or cocaine or MDMA, because it's not a drug that would enhance the effects of the drug that you're trying to sell. However, sometimes it shows up accidentally because people have multiple things on a table. Sometimes people sell it accidentally because they've got a bunch of things on them and they're not sure which is which. Sometimes people use it accidentally. And there definitely is a lot of stimulants put into fentanyl. So the other direction does happen. People selling drugs do put stimulants into fentanyl because it helps to cut the sedation of the drug.
Are you are aware of any studies looking at the fentanyl strips and whether or not they are making any difference at all? I work with a younger
Yeah.
population and they're all for fentanyl strips. And so I'm like, I'm just
I
wondering.
think Dan Safe has like that as an intervention.
Yeah, DanceSafe does, and the state actually provides us with fentanyl strips. So it's out there, and you can see them if you go out to bars. Sometimes you'll see them next to the bathroom, next to the Narcan, next to the bathroom. And I think it's a good intervention for people that aren't using, and probably helpful for people that aren't using drugs heavily on a regular basis,
Mhm.
in that it's an effective way to check your drugs. For people that are using drugs multiple times a day, it's less helpful and less of a viable tool. And that, of course, represents the majority of people that end up deceased. So I haven't seen, and that's where most of the research is done. I haven't actually seen studies of fentanyl test strips among youth, but that would be a population that personally I would be inclined to think it would be beneficial for.
Yeah, it was with your expertise, it was my curiosity too, with the population that I see.
Yeah,
And
add my curiosity to that.
Yeah, it's a good question. I do like that tool in certain circumstances. The one caveat with that one is that methamphetamine tends to cross-react and make a false positive on that test. So you have to dilute methamphetamine in about a half a cup of water, because those tests were designed to test urine, not drugs. So it has to be diluted, or you get false positives with methamphetamine and also with diphenhydramine. So it's a little, they're imperfect, but helpful, especially for more recreational use settings.
yeah, I'm talking the group that meets at Alta Plaza Park and starts sharing whatever else anybody else might have. That it seems to have been a good preventive strategy, put it that way. So,
Yeah, no, I think I think they're a net positive. Unfortunately, they're not going to reverse the crisis, but provide some help in some circumstances.
thank you. This was really helpful. And yes, I had multiple questions, but um, your presentation and how you walked us through in all of I was hoping for what you were talking about in being able to add to what was on the piece of paper and I really appreciated it. It was great.
Great, thank you so much. I appreciate the opportunity to be here and speak with you.
All right, thank you. We can move on to item 5, emerging issues. Anything from you, commissioners? There's nobody on the line. All right, hearing none, we can go to public comment. And since there's no one on that line, on the line or in the room, we could consider motions for adjournment.
I so move to adjourn the meeting.
Second,
And could we have all in favor?
aye.
Aye.
All right, thank you. And thank you all for attending. This is now the end of the meeting.